Morning, everybody. This is CVPP, Cardiovascular Pulmonary Pathology Lecture, and we are on week 7. Can you believe it? We made it this far already. 100% online, and it is Tuesday, and it is the spring of COVID 2020. Here we go. I guess it's COVID, not COVID, COVID. All right, where did we leave off? We were talking about a patent or a probe patent foramen ovale or a PFO, and of course it's a failure of the fossa ovalis to completely seal, specifically the valve and the limbus. Remember the little welder guys in there? The valve and the limbus don't scar together like they're supposed to, and can be a problem it happens in 25% of humans, that scarring happens. And usually it's no big deal unless you develop pulmonary hypertension, then it's a big deal. But if you never have problems with your heart or lungs, you're not going to have to worry about this thing. And pulmonary hypertension, of course, causes a higher pressure in the right atria than in the left atria. And remember, these probe patent foramen ovales are pressure closed. We need normal higher pressure in the left atria to push on it and close it. Right, so here's a normal, healthy heart. And we have higher pressure here in the left atria. And we have lower pressure in the right atria. And the valve in the limbus, there's the valve, it's pushed together. So it seals because of the pressure. So no problem unless the pressure rises greater than the pressure here in pulmonary hypertension. Then this blue blood can sneak right in here and it can mix in and the patient becomes cyanotic. Body does not tolerate deoxygenated blood getting mixed in with the good oxygenated blood. If you have a hole in your ventricle and you have some of the red blood, can I change that to red? How hard is that? If you have a hole here and you have red blood, you have oxygenated blood dumping into here, body tolerates that much better, but it does not tolerate the deoxygenated blood getting into the oxygenated blood. All right, Eisenmenger syndrome. Did we talk about that? I think we did before, but if not, let's talk about it. So if someone has a PFO and they develop pulmonary hypertension to the point, it should be the point. Let me make a fix here. To the point that the right atria becomes higher than that of the left, then you get a pathological shunting of blood. Like we said here, you get this blue blood going in, this deoxygenated blood going in there. That's a pathological left or right to left shunt. And when that happens, there's a term for that, and that's called Eisenmenger syndrome has occurred. Eisenmenger syndrome. And that's deoxygenated blood flows or leaks or shunts from right to left. What's the sequelae of Eisenmenger syndrome? Deoxygenation. You become hypoxemic. Right? What's that mean? That means that your tissues are struggling to get the amount of oxygen that they deserve. And that situation will be corrected. We'll learn about erythropoietin in a little bit. But yeah, that's not a great thing. You can become symptomatic. You can become lightheaded, confused, a little cyanotic. We'll list the symptoms officially in a minute. But that's one of the sequelae. You become hypoxiated. Another sequelae is now that you have a flow going like this, possible flow of blood going like this, as well as because we have higher pressure over here, if you get an embolism that comes in through here and dumps into here, because of this high pressure, the embolism could jump ship and jump into the right side, and then that embolism could go anywhere. It could go up to the brain. It could go anywhere your arteries go. So that's not a good thing either. So a venous embolism, that's called, when a venous embolism jumps into the arterial side, into the arterial circulation, that's called a paradoxical embolism. Paradoxical embolism. No more vocabulary words for you. And everything I just explained, it usually comes from the deep systems, maybe the popliteal vessels or the posterior tibial artery, and it jumps ship. It goes through the foramen ovale into the left atrium, and now it can go anywhere. And it's just like a Russian roulette. Where does the ball go? Or I guess that little, what's that called, roulette? Where the little ball, who knows what, spin that wheel and the ball flies around in the wheel and jumps around and it'll finally land somewhere. It's the same kind of thing here. Maybe it'll go up the left common carotid artery, go into the internal carotid artery, go up into the brain and circle Willis and cause a stroke. You could die from that. Maybe it won't even make it out of the ascending aorta. It'll go into the right or left coronary artery, and it'll cause a massive heart attack. If it's big enough, it can completely occlude that. You'll have worse than a widowmaker. Maybe it goes all the way around the aorta, down the ascending aorta, past the celiac trunk, and then for whatever reason, the currents push it into the renal artery, and it doesn't completely occlude blood, but it decreases blood flow, and you get yourself the R2A system turned on, so you get a hypertension. Or if it completely occludes the renal artery, you get a renal infarct. See the deal? There's one that goes in the celiac trunk, go in the splanchnic arteries. So it could go anywhere. Arterial embolisms, whether they're paradoxical or not, or whether they're born from the atrium, very, very dangerous. And let's see, we talked about this, pulmonary hypertension. It could get through the hole, or it could also get through, so we're talking about a probe patent foramen ovale, but we're going to look at other holes in your heart that are there all the time, like an atrial septal defect, ventricular septal defect, and we're going to look at a patent ductus arteriosus as well. And yeah, so those are holes. If you get pulmonary hypertension, you could get a passage of a venous embolism in through those holes as well, and it could cause a stroke. So those are also paradoxical embolisms. It doesn't have to be just the patent foramen ovale. Okay, but you have to have pulmonary hypertension, is the point there. Okay, now this is pretty rare, but there are some reported theories or cases. That's not super cast in stone. But when you're doing a heavy squat, or you're on the toilet and you're constipated and you're pushing really hard, some believe that you can raise the pressure enough in the right atria to allow a embolism to jump ship and go through the patent foramen ovale. So it is possible, but it's pretty unlikely that'll happen. If you don't ever get pulmonary hypertension, you'll never have that 25% of you who have a patent foramen ovale, you'll never have a problem with it. Probably wouldn't be good to be a smoker and have a patent foramen ovale, because that increases the chances of COPD diseases. COPD, of course, will cause pulmonary hypertension in most cases. There's some research on stroke in paradoxical embolism. About 50% of patients who've suffered what's called a cryptogenic stroke. Do you know what that is? Cryptogenic stroke. That means they had a full-blown stroke and they go in there with CT and MRI and they don't know what happened. There's no reason for it. So that's a cryptogenic stroke. And there's about 50% of those patients, if they do some testing of the heart and ultrasound, sure enough, they have a probe patent foramen ovale. And so that kind of goes back to this line of research where maybe they were super unlucky, they were on the toilet, whatever. They had very bad luck where an embolism passed right next to the foramen ovale, and all of a sudden the pressure raised up enough to push the embolism into the right side, into the right atria. So, and further research, if they had those who had this surgically closed had a decreased chance of reoccurrence of the stroke. So, there is an association with chronic migraine headaches and probe patent foramen ovales, especially the type of migraines that you have an aura with. And some research found that surgical closure of the PFO completely eliminated the migraines. So that's very interesting. Still a little controversial. Some research hasn't found that, but it certainly is quite interesting. If it's true, that means that these people are somehow getting many embolisms are actually jumping over into the arterial circulation. And there's actually, I took this out, but there's really new research that does find that some people without pulmonary hypertension are getting paradoxical emboli, and they don't know why. There's no rhyme or reason to it, but it's just new research, so I didn't put that in. It's definitely not in the board books yet. What are the symptoms? Oh, I always ask this question. I don't always, but I usually do. What are the symptoms of a probe patent foramen ovale? The usual symptoms, assuming you're healthy. You don't have any symptoms, right? Because the valve and the limbus are sealed, pressure sealed, and therefore you don't have any shunting of blood. There's no left to right shunt or right to left shunt of blood if you don't have pulmonary hypertension. All right, so no symptoms. You have to get pulmonary hypertension first, and then you would have a right to left shunt of blood. Okay, if you have pulmonary hypertension, you never have a left to right shunt of blood, right? Because of pulmonary hypertension means the right side of the ventricle and atria have higher pressure, and so if there is a hole to go through, it'll go the other way. It'll go from right to left. If a normal person has a hole in their heart, like an atrial septal defect, there's always a hole there. They will always have a left to right shunt. And after many years, if all that extra blood ruins the microcirculation of the lungs, they might develop pulmonary hypertension, and that left to right shunt might turn into a right to left shunt, a pathological right to left shunt. Way ahead of my slides. This patient has COPD, so they have really high pressure over here in the right heart, in the right atria and right ventricle. So what? Well, let's make the ostium for the inferior vena cava. So we had a blood clot break loose. We had thrombus break loose into an embolism. It's headed for the lungs. Going to be a pulmonary embolism. It comes shooting out here. Remember, the blood comes out of the inferior vena cava, the orifice here, and it bangs right into the fossa ovalis. Because it used to go that direction in vivo, right? That used to be a hole, when you were still developing, there was a hole there and the blood shot right over there. But now if you have higher pressure, that piece of thrombus can jump ship and end up in the left atria, and there it goes down. Okay. And let's see. Yep. Everything I pretty much said. This particular one ended up going up the pulmonary trunk, around the aorta, went through the left common carotid, through the left internal carotid, got up into the circle of Willis, and the patient had a stroke from this. What about the symptoms of hypoxia? So there's exertional dyspnea, so you get tired walking up the stairs. There's symptoms of the tissue not having enough oxygen. There's presyncope, you get dizzy, especially when you're walking up the stairs. Your heart's going to try to compensate, so your heart's going to be faster. You're going to have tachypnea. You're going to be breathing harder to try to compensate. You might have no energy, be lethargic. You could have a headache is common. Cough is common. You might be a little white in color. Have pallor, that's said. And you could, if something isn't done, it could turn into a blueness. Your fingernails and fingertips could be blue. Could become cyanotic. Could become confused. Coma. Yeah, those are all signs of not enough oxygen. How about some blood findings in patients with hypoxia? So the tissue hypoxia throughout the body, it stimulates cells in the bone marrow to make more red blood cells. Specifically, we'll talk about EPO in a bit. But bottom line is because you're always hypoxic, it's just like people who go up to altitude, up to Vale, 8,300 feet. It's pretty darn high. So your body actually grows more red blood cells to help carry more oxygen. And so these people will develop what's called a secondary erythrocytosis. If you do a blood smear, they have way too many red blood cells in their blood, and the hematocrit is raised. The blood is thicker. Not to be confused with blood cancer, like polycythemia vera can also raise hematocrit. Cancer makes too many, bone marrow cancer makes too many cells, blood cells that way. All right. Atrial septal defects, congenital heart conditions. So that's the end of the patent foramen ovale. Now let's talk about some flat-out holes that are always going to be, well, if they're really small, they can heal, but these are real holes in the heart. So ASDs, they are a member of the congenital heart disease family. Sometimes congenital heart disease is also called cyanotic heart disease, cyanotic heart defects. The members include the ASD, atrial septal defect, a VSD, ventricular septal defect, patent ductus arteriosus, and the tetralogy of Fallot. Those are the members of the congenital heart disease family. And it's nothing more than a hole in the intraatrial septum or the interventricular septum or the ductus arteriosus fails to close, and you have remember there's ligamentum arteriosus, we saw it on the cadavers. That was ductus arteriosus in vivo, and that was a blood shunt, and it never closed. So you're leaking deoxygenated blood into the oxygenated blood. We'll look at that in a bit. But yeah, those are the ASDs. They can be everywhere. This is just a few of the spots they can be. That's the intraatrial septum. So the most common congenital heart defect in adults. Look at all the stars. I always ask this question. Okay, so an atrial septal defect is the most common congenital heart defect in adults. So how do they make the diagnosis of a congenital heart defect? They have to become hypoxic, or there have to be some symptoms, and the symptoms are hypoxia, or maybe it's the extra blood cells as well. Why in adults? This is when the symptoms of hypoxia show up in adults. Well, why not kids? Right? How come it doesn't show up in kids? How come it doesn't? Because the holes are typically pretty small. And remember, the pressures in the atria are not nearly as great as they are in the ventricles. So therefore, if you get a left to right shunting of blood through an ASD, it's not going to be a ton of blood. So it takes a long time for that extra blood passing through the right heart and into the lungs to do damage. Right? So everything I said, atrial pressures are low compared to the ventricles. Therefore, the right heart doesn't receive that much extra blood, unlike a VSD where it receives tons of extra blood. So extra blood, who cares about that? What does that do? Well, the extra blood will go through the right heart and down into the lungs. And when you're pushing globs and globs of blood through the lungs, the microcirculation is not designed for that. It stimulates inflammation, fibroblast formation, and you start to get scar tissue laid down, and starts to squeeze some of the vessels, so it's difficult for the right heart to push blood through the lungs that are so scarred up. And the right heart, as we've talked about, is not designed to do that. It's a wimp. And it will wear out, and you'll get right ventricular hypertrophy, and then it'll become flaccid and it'll lose its power, and you'll have right heart failure. But all this because there's only a little bit of blood going. It takes a long time to develop this pulmonary hypertension. Right, so now everything I said, so what? What if the microcirculation is damaged? Well, I said it's going to result in scarring up of the microcirculation. You can't push blood through it anymore. And therefore, the bottom line is you get what we've been talking about, pulmonary hypertension. So pulmonary pressure rises, you get pulmonary hypertension. And that can cause a reverse shunting of the blood. In other words, you have a pathological right to left shunt. Should never be a right to left shunt. It's always when you have a hole in your either the ventricle or the atria, the pressure is always higher in the left heart. So normally you have a left to right shunt. But once you've wrecked your lungs and now you have pulmonary hypertension and you reverse the shunt of blood, that's not good. That's called Eisenmenger syndrome, right? Reverse shunting. So once the blood reverses, the patient has Eisenmenger syndrome, and they will become hypoxic. And if it's a hole in the atria, it's probably take 30s or 40s, or maybe even longer before it develops. Why? Because not much blood passes over. Why does the patient have hypoxia, or why doesn't the patient have hypoxia immediately? Well, because they're losing oxygenated blood into deoxygenated blood. As I said, too much blood is going to the lungs, but they are losing some of that oxygenated blood, but it's not going to the body. It's going to the lungs, but it's not being transported to the body, and the body tolerates that scenario better than when that good oxygenated blood headed for the body in general. When that's poisoned by deoxygenated blood dripping into it, that's when when hypoxia occurs, the symptoms of hypoxia. Patent ductus arteriosus is notorious for doing that as well, as we'll see. So ASDs, the incidence is about 0.1% of the population. I think it was 0.06%. I rounded it up to just 0.1. 18% are associated with genetic mutations that don't the septum secundum doesn't close right. There's a whole bunch of mutations. They're definitely more common in females than males. All of the congenital heart defects are, for that matter. And about 33% of the patients with any congenital heart disease, this is the type you'll have. So it's a pretty common one. All right, this is interesting here. You can see we got some holes right here. There's a hole there. There's a hole here. Septum secundum hole. There's a much bigger one there. Another one here. These are all atrial septal defects. What's this one though? Yeah, there's the limbus, right? Here's the valve. So that's a patent foramen ovale that, because the patient died and there's no pressure there, it just kind of opened up. All right. So atrial septal defects always allow shunting of blood to occur. Normally the shunting is left to right because the pressure on the left is higher than the right. But as I said before, and you're going to lose some of your oxygen, but it's not going to poison the good blood going out to the body. So not that big of a deal. You tolerate that much better. If there's a bigger hole, then you can start losing, you can get Eisenmenger syndrome much quicker. All right, here's a patient who died of, the entire valve is gone, isn't it? This is called an Ostium Secundum defect. Ostium Secundum defect, and it's a big one. And the patient was football practice doing wind sprints, and they dropped dead. And autopsy showed this. Natural history, well, if the hole is large enough, you'll get Eisenmenger syndrome. This is kind of everything I've already said. The extra blood damages the microcirculation, makes it hard for the right ventricle to push. Remember, the right ventricle is a wimp. It's got a really easy job. Normally, it's not designed to muscle up like the left heart can do. And that'll result in pulmonary hypertension. It'll finally cause a shift of the blood flow from was left to right, and now it's pathologically right to left. And that's called Eisenmenger syndrome again when that happens. What is the sequelae of Eisenmenger syndrome, i.e. a right to left shunting of blood through an ASD, a VSD, or a patent foramen ovale for that matter? Well, the right atria and the ventricles become stretched out from all that extra blood, and they're hypertrophic. They can fail because of the pulmonary hypertension. We've talked about that. Remember, this situation would not be caused by cor pulmonale. This is a congenital problem with the heart. It has nothing to do. To have cor pulmonale, it has to be a lung problem. And some other sequelae, it increases the chance for paradoxical embolism, as we said. Paradoxical embolism can cause a stroke, myocardial infarction, infarct of the liver, spleen, or stomach via the celiac trunk. I've asked that question before. Just see if you remember your anatomy. What's the celiac trunk connect to? That's a great anatomy question, isn't it? Splenic artery, you can get an infarct of the intestine, small or large intestine, if you get a embolism stuck in the superior or inferior splenic artery. You can, on a soft tissue film you can see a weird looking heart. It's definitely not left ventricular hypertrophy. The heart has actually rolled counterclockwise. I don't know if I can draw it, but it's rolled like that. And therefore, remember, the right atria is all right here. That has rolled over with it, and it gives you this weird bump. And the aortic knob you can't see that as much anymore either. So that's classic right ventricular hypertrophy. Left ventricular hypertrophy is, as you'll learn, you get the heart sticking out like this down here. It pokes out. Right ventricular hypertrophy, it pokes out more subtly too, I should add, up here. Other clinical findings. So you're going to get a murmur if you get your stethoscope out. You get what's called a holosystolic murmur that goes, holo means through, so it's not remember the normal heart sound, lub-dub, lub-dub, S1, S2, S1, S2, S1, S2. So a holosystolic murmur goes whoosh, 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 whoosh. You can't hear the lub-dub, lub-dub. You can't hear any of them. It's blocked right out by that. It's best auscultated down. Erb's point would probably work, or down at the tricuspid area is the best spot to hear this type of a whooshing murmur. It's closer to where the ASD is. You could get a thrill if they have Eisenmenger syndrome. Blood is going from right to left. If you put your metacarpophalangeal joints down in the left lower sternal border, you might feel a purring cat there. Remember the purring cat? That resembles a systolic thrill. You could also get a secondary erythrocytosis as well. That's more of a lab finding, though, isn't it? I'm not sure why I put that over here, but it's really more of a lab finding. You could also, so if you can palpate a thrill with your metacarpophalangeal joints, then you could maybe even see a visible heave, kind of an upchucking or a little pulsation down in the lower left peristernal border. And those are called heaves. And then you might see something weird, something called clubbing. Clubbing. And no, we don't mean the disco days back in the days. We can't even do that now, I don't think. Maybe in Wisconsin you can do. Is Wisconsin they completely open back up? This is clubbing back in the day. So we need to talk about clubbing. So what is it? It's a painless enlargement of the nail plates, the distal phalanges. And the pathophysiology is not understood well. It's caused pathologically. We know, like if you do histologically, I should have said, let me make a note to change that to histologically, 170. Histologically speaking, if you do a biopsy of the clubbing, there's all sorts of growth connective tissue and scar tissue underneath the nails and all sorts of new vascular tissue. But the cause of it is still debatable. Here's classic clubbing. What else? They have clubbing and what else? What if I put this picture on the test? This is a great example of blank and blank. Clubbing. How's the nail color? Cyanotic. So this is clubbing and cyanosis in someone who developed Eisenmenger syndrome from a ventricular septal defect. So the etiology, again, is controversial. One theory is that chronic subclinical cyanosis. So the tissue is just always hungry for oxygen, causes the genes to be turned on, which makes growth factors, and the growth factors kind of get swept downstream. Either that or where's the place in your body that has the worst circulation of all? Tips of your fingers and tips of your toes. And so you might be getting growth factor release in response to hypoxia, and it causes extra blood vessels and tissues to grow there. Problem with that theory, clubbing can also be seen in Crohn's disease. And Crohn's disease has nothing to do with hypoxia. So again, they need to keep working on that because they don't know they don't know what's going on with this. So what are the associated? Why am I even bothering with clubbing? Because there are some important clinical comorbidities with this condition. 80% of the time, someone with clubbing will have respiratory problems, like a little cancer of the lungs, cystic fibrosis, bronchiectasis, lung abscess, interstitial fibrosis, pleural empyema. Right? So it more often than not, it means some kind of lung problem. And then 33% have a miscellaneous, or 13% have a miscellaneous type of disorder. So congenital cyanotic heart disease, hey, that's what we're talking about right now. So about 13% of the clubbing pie, if you see clubbing in somebody, 80% of the time, it's going to be something's wrong with their lung. Maybe they have an infection, probably more likely than cancer, but they could have cancer. Liver cirrhosis could also do. It's been associated. Oh, here comes the kid brigade. The menaces of the neighborhood are out. Hopefully they won't scream too loud underneath us. Underneath my window. So some other causes. Subacute bacterial endocarditis. In fact, that was one of the first cases of it came from a medical doctor discovered he had endocarditis. I think it was bacterial. Not sure what the cause was. But he noticed his fingernails getting big, and he had a recurrence. He had it treated with antibiotics. It went away. And then years later, he noticed the fingernails getting swollen up again and big, and he went in before he had any symptoms, and sure enough, it had come back again. So subacute bacterial endocarditis is a cause. Chronic diarrhea associated with that. Infectious endocarditis, infective endocarditis. I mean, that is bacterial endocarditis. Those are really AKs. Or infectious is more, because it could be a virus, could be a yeast, could be something else. That's more of a general category. Crohn's disease, as we said. And then 7%, I should have made its own slide, but I've had students with this, and they've all been fine. So sometimes it makes me wonder if this isn't a bigger number than 7%. But 7%, according to this research, says there's nothing wrong with the patient. They just have it, and then they don't understand why. Just the way it is. See, this one looks better, doesn't it? Definitely clubbed, but it's not cyanotic. Right? Then we have Shamroth sign is a way to see. We can all test it right now to see. Somebody's probably got clubbing out there, I bet you. After this video has been aired for about 6 months, I guarantee you somebody will find clubbing. And it's probably going to be normal, but you got to get it. You got to get the lungs checked out, right? Got to get worked up if you do have it. But a quick way to test it is to just take the dorsal part of your fingernails and your dorsal phalanges and put them back to back like this. So everybody do this right now. And then see how it creates a little window right here? So hold your fingers up to the light or a piece of white paper. I'm doing mine right now. And I can see a lot of daylight here. There's like a little diamond or a space. If you have a space, you're good. You don't have any clubbing. If you don't have a space, you got a little bit of clubbing going on. And then you can actually get a little protractor out or a little measuring device, and you can measure the angle. Mild clubbing is a straight shot between your nail and the distal phalanx. And if the nail rises up enough, that's how you find advanced clubbing. Actually, aren't those angles reversed? Yeah, because you think the angle would go like this. Yeah. Anyway, no stars on that slide. How about some other causes of cyanotic right to left shunting in people? So it's not always caused by this Eisenmenger syndrome. The shunting is not always caused by the lungs getting scarred up and pulmonary hypertension occurring from that. Any type of a beaver dam can cause this. Any type of a downstream beaver dam from the ASD or from the probe patent foramen ovale for that matter. Anything downstream can raise the pressure upstream, right? That's the definition of a beaver dam. So what's classic? People with tricuspid stenosis, pulmonic valve stenosis. That's definitely going to raise the pressure. Tricuspid stenosis, where will it raise the pressure? Good, in the right atria. What about the right ventricle? No, that'll be lower pressure. Beaver dam is, the right ventricle is downstream from the tricuspid valve. See how that works? What if it's a pulmonic valve? Where would the pressure be raised? Right atria? Where else? What about the right ventricle? Yeah, right ventricle as well. Okay, see how that works? So that can cause a Eisenmenger type syndrome. So it's not always destruction of the microcirculation in the lungs that does it. All right. So I'll just show you here. So we know the flow of blood comes into here, right? This is the right atria. The blood goes through the mitral or through the tricuspid valve. I hope I didn't say mitral valve over there. I meant tricuspid valve. Yeah, it says tricuspid. And then it goes through the pulmonic valve here, number 7, up the pulmonary trunk, and then into the right and left pulmonary arteries. But if we get a beaver dam, if you get tricuspid valve stenosis, and these don't work very good, pressure's going to build up here. So if you got a hole, once the pressure gets high enough, the blood's going to flow to the left side. So then you have a pathological left to right shunt. Same thing here. If you got... Let's see, can I erase this? So if you have a beaver dam here, if the pulmonic valves are stuck in stenotic, then the pressure builds up because the river flows this way, right? Pressure builds up upstream, so you get increased pressure in the right ventricle and increased pressure in the right atria. So if you have any ASD or even a VSD, it's going to cause, once the pressure gets higher than on the right side, you're going to get a pathological right to left shunt of blood that way. See how that works? Other causes, pulmonary embolism, same thing, right? What if an embolus gets stuck in here, right? Do I need to draw this? Oh, you got a big embolism. Let's say it gets stuck right down here. No, well, you won't live. Let's say it's probably going to get stuck right here. That's just like having pulmonic valve stenosis, but it's a beaver dam. So this will increase. Pressure will increase here. Pressure will increase here. I mean, it'll go up here too, right? Pressure in your jugular will start popping out. You'll start getting some congestion in your liver. It's the beaver dam story we talked about the first day. All right, so that can do it. How about complications from Eisenmenger syndrome? When I say Eisenmenger syndrome, that just means a left to right shunting of blood. So right heart failure, right? Can that do it? Yeah. I mean, the Eisenmenger in and of itself, the right heart failure is already started because of the damage to the microcirculation of the lungs. So that's already going on, but it'll definitely, it's not good. But I mean, that one really, I guess I could leave it there, but that's really more, that led up to the increase in pressure on the right side of the heart. Hemoptysis, might be spitting up a little blood, again, secondary to the pulmonary hypertension problem. Kidney problems from the lack of oxygen. I mean, any problems in all your organs. Secondary erythrocytosis, we talked about that. We can add a little more complexity to it now. When the kidneys become hypoxic, they're the ones that cause the bone marrow to work. They release something called EPO, erythropoietin, and that stimulates the bone marrow to make more red blood cells, and you get thick, too much red blood cells in your blood. That's called erythrocytosis, secondary erythrocytosis. You'll also have an increased hematocrit. You might get some heart arrhythmias too as the heart becomes ischemic. It starts getting cranky and twitchy. Let's look at some specific atrial septal defects. Now, I just made these slides. I redid these slides this morning, so I forgot to put stars. And normally I say no stars, no test question. Though this slide will be on the test. So write your stars in here yourself. Here's, you got to know the 4 types of atrial septal defects. There's an Ostium Secundum. If you can only remember one, this is the one to remember. It's by far the most common, Ostium Secundum. Then there's a Ostium Primum defect. Then there's a Sinus Venosus defect. And then there's a coronary sinus defect. There's actually 2 that could, the coronary sinus. It's also known as the inferior sinus venosa defect. And, now what do we got going out there? Looks like we got the landscapers coming by. Hopefully it won't get too loud. So we're going to look at these. Right, here's that view of the heart that we're always looking at. There's the fossa ovalis there. So there's a septum secundum defect occurs in the valve. And I have slides on all this stuff, but there's the superior sinus venous defect is up here. We'll look at that one. There's a coronary sinus defect. That one's pretty rare. It's down here. The septum primum defect can be dangerous. Remember, we said the atrial interventricular the intraatrial septum does connect to the powerful left ventricle, and you could get a hole in that region, allowing a lot of blood to get backwashed into here. That's pretty rare too, though. Let's go through them, though. Ostium secundum defect, by far the most common type of ASD, 80 to 95. Rubens gives it 85 would be the average. More common, all of these are more common than females. This is a true hole in the fossa ovalis. More specifically, it is right in the middle of the fossa ovalis. I already showed you a picture of one. A huge one. And recall that the valve of the fossa ovalis is very, very thin. We can see a light through on the other side. It's probably why it's the most common. It's easy to punch a hole in that tissue. Not particularly dangerous as long as it's not too big. They're usually not gigantic, so they can heal with the passage of time. All right, so the ostium secundum defect, it's not the same as a patent foramen ovale, of course. Patent foramen ovale is a failure of the limb and the valve to weld together. This is a hole. It's a real hole. On a normal human, they always allow a shunting of blood, but it will be a left to right shunting until it naturally heals up. If it's big enough, it may not heal, and it could eventually cause Eisenmenger syndrome. But it takes a long time because there's not a lot of pressure going on in the atria. And so it'll take a long time, 20, 30 years sometimes. But it could cause Eisenmenger syndrome. Not as easily as a ventricular septal defect can do. Right, a superior sinus venosa defect. That represents 5% of the atrial septal defect pie. And this is a problem with the embryological development of the sinus venosus. I won't say anything more except that. Some authors don't like to classify this as a true atrial septal defect because some of it might be in the fossa ovalis, but some of it might be in the tissue surrounding that area. So it's typically not involved. Oh, it's not involved with the fossa ovalis typically, the septum primum or the septum. It's in the kind of the area around the fossa ovalis. But we will call it a member of the ASD family, as our board books do, and so it is a congenital heart defect. So the superior sinus venous defect, it always communicates. There's an abnormal communication between the right pulmonary vein, and then there's a choice. So that connection is always there. And then there's also usually a weird connection between the superior vena cava and the right atria. Remember, the pulmonary veins are coming where? From the lungs or going to the lungs? They're coming back from the lungs. Okay, so the right one is the right pulmonary vein usually develops an abnormal connection to the vena cava or the right atria, or both of them. All right, and so we have nice oxygenated blood being spilled into the deoxygenated blood. That's when this one's not perhaps quite as bad because of that. But here's the deal. So at least we don't have poisonous deoxygenated blood mixing in with this one. But here's a cartoon. Here's the right atria here. Here is the inferior member of the right pulmonary vein, and it's got an abnormal communication between it and the superior vena cava. And here's another abnormal communication between it and the right atria. So all this nice oxygenated blood heading that way, right? It's leaking. Some of it's leaking into this deoxygenated blood. But at least we're not getting any deoxygenated blood leaked into it. So at least that's a good thing. Okay, and it's not typically as dangerous as I said because it's under fairly low pressure. We could also add that there's no deoxygenated blood. I'm not going to write all this out. There's no deoxygenated blood getting mixed in with the oxygenated blood. Maybe I'll make a note. Okay, very rare. Inferior sinus, we're not going to talk much about that. It does happen. There's a connection between the inferior vena cava and the right atria. Sometimes it can connect directly to the left atria. It's super rare, but that would be bad, right? Because you're dumping deoxygenated blood right into good oxygenated blood. All right, now an ostium primum defect. So this is a hole kind of right down here in the interatrial septum by the tricuspid valve. So it may, this is the one that can be a little dangerous because it can communicate into the plane of the pages, the left ventricle. This is the right ventricle in this cartoon, but the left ventricle would be behind it, and this could communicate with it. If it does, then you have yourself a arterial ventricular septal defect, and that is not good because you can have some really high pressures blowing blood into the right atria here, and you can develop Eisenmenger syndrome more quickly if that's the case. All right, much more dangerous. Everything I said, it's under much higher pressures. Eisenmenger syndrome more quickly. These should quickly be repaired surgically if you're found with these things. Remember, here's a dangerous one, but here's the
the atrioventricular septal defect going right through here. So you could have blood blowing out of the left ventricle into here, and that would put quite a good volume of blood in here, and that could wreck the microcirculation of the heart, right? Because the right atrium, all that blood is going to pass through the heart, and it could wreck the microcirculation. What are the treatments for these things? Close them up. You surgically close them up if they become symptomatic. And it's pretty successful. The trouble is, there's a surgical closure of one, really pretty big one. The problem is now we have a surface for the bugs to kind of gather on, and you can get a bug ball. Well, you could get a bug ball embolism release, but you could get an infection of the heart from these things. So you could get endocarditis. That's one of the sequelae. Patent ductus arteriosus. I just threw these in there about 2 hours ago. So let's talk about it. These might be not the greatest slides, but they'll get better as time goes by. So a lot of AKAs, PDA, PAD sometimes, patent arterial duct, common truncus, persistent truncus arteriosus, the embryology authors like to call it. I call it a PDA, patent ductus arteriosus. So normally, embryologically, there is a open shunt right here, the ductus arteriosus. Why do we need that open shunt? Because the lungs aren't working. The lungs can't accept oxygen. And so remember that we have oxygenated blood coming in right here into the right atria. Right, that's all oxygenated, and it's shot into the left atria. It's shot over here. Well, it's not showing up, but it's shot over here, and so that's how it gets its oxygen. But some of the blood, the rich oxygenated blood, is shot that way. Some of it still goes down here and pumped out toward the lungs, and it can't get into the lungs, so it's only 12% goes this way and this way into the lungs. So it's like an overflow valve. So you have this deoxygenated blood mixing in with the oxygenated blood here. And that's okay embryologically. We can handle that. But when you're born, this has got to scar shut. Remember we had that long cord, ductus arterial, or that long cord that we saw in a paint, or brain's blanking. Not a ductus arteriosus. Ligamentum arteriosus, right? This was called ligamentum arteriosus. That is a scarred up ductus arteriosus. That's normally what happens. But in some people, that never scars up and it becomes an opening. And therefore, when you're born and the heart starts blasting blood out of here, you're getting deoxygenated blood shot right into the aorta. So the flow of it would be like this. And I don't know why I have trouble writing with this thing. Even if I go to blue, well, maybe blue will work. Yeah, that'll work. So you're getting deoxygenated blood shooting right through this patent ductus arteriosus. And we know the body does not tolerate that well, so you can become hypoxic quite quickly with this. And the babies are caught with this right away. Normal ductus arteriosus closes or dries up before birth. It forms ligamentum arteriosum. So we said, I guess I could have just turned the page for my little mind blank there. But yeah, so normally the ductus arteriosus dries up before birth and it forms the ligamentum arteriosum. We saw that on the hearts. The truncoconio ridges fail to form and spread out and seal that off. Very dangerous because large amounts of arterial blood are lost. Well, it's not that it's really lost. It's diluted, right? The deoxygenated blood. I'll fix this for the slides. Jeez. That's what happens when I write slides the first time. Fix. So large amounts of deoxygenated blood are forced into the good oxygenated blood. I'll fix that for you guys. Okay, normally it closes up, dries up, everything I already said. I think we got that already. It's dangerous because large amounts of arterial blood are lost. Yeah, a child becomes hypoxic very quickly, almost always accompanied by a ventricular septal defect. So these are, I forget what the number is, but I want to say it's around 50%. So it's very common to look for another defect. And this one's no joke. 65% of the newborns this one is no joke. 65% of the newborns will be dead within 6 months if this is not fixed. So this is nothing to monkey around with. Let's see how we're doing on time. I think we can go a little further. Let's do the interseptal defects here. So these are the interventricular septal defects, or the VSDs. Remember, the interventricular septum separates the left and right ventricles for the most part. It also separates the right atrium from the left ventricle a little bit. There is a membranous portion that's thin and a thick muscular portion. Guess where most of them form? Well, of course, in the membranous portion. Thickest point, yeah, we said that. The interventricular septum is thick in the muscle, skinny in the membranous. Bundle of His actually lives in the membranous, the region of the membranous. And unlike the atrial septum, it is normally intact. There's no hole in it that needs to be closed or anything. It's just, you can see it right here quite nicely. Nice sheet of muscle right here. And then there's the membranous portion, which is really skinny. Okay, this is an anterior cut. This, if you go deep, if I went deep enough to show you the right atrium, you wouldn't see this anymore. It's down in the plane of the page. But right here is a more superficial cut. Isn't there a quicker way to delete this stuff? I guess not. Boy, they need to come up with something better. Come on, PowerPoint. Microsoft Office. So the membranous portion, we already said that. It's close to the aortic valve. It's very thin. It's delicate. That's why most of them occur there. Let's look at the ventricular septal defects. It's just a hole, just like the atrial septal defect. It's a congenital hole. You're born with a hole in your heart. This time it's not between the atria, it's between the ventricles. It is the most common congenital heart defect in the pediatric population, period. Remember, the most common congenital heart defect in the adults, because there wasn't a lot of blood leaking into the right side, atrial septal defect. But this is the most common one in the pediatric population. How come? We'll cover it in slides in a second. The ventricles are under high pressure, so you're going to have you're born and you have a huge shunting of blood from left to right, and it's going to overload the lungs real quickly. So you develop Eisenmenger syndrome quite quickly. I guess the next slide was this anyway. Everything I just said. Ejects too much blood, way more dangerous. Eisenmenger syndrome can come on quickly. Who cares about Eisenmenger syndrome? That when you have Eisenmenger syndrome, you have symptoms of hypoxia. The epidemiology. So about 2.5% of all births. So this is much more common than atrial septal defects are. Remember that was like, what was that, 0.06 or 0.05, I think I said. And 70% of these occur at the weakest point, which is the membranous interventricular septum. 30% occur in the muscular interventricular septum. And yeah, here's a nice cartoon. Right? So high pressure, we got a hole in the muscular portion of the interventricular septum, and the blood is dumping. We're losing oxygenated blood. And that's not the problem. The volume of the blood is the problem, because now we got way more blood going to the lungs than normal, and it's going to wreck the microcirculation, cause scarring, cause pulmonary hypertension, and it's going to eventually change the flow. And to change the flow, you're going to go that way. and it's a big hole, you're going to have a lot of deoxygenated blood going in here. So Eisenmenger syndrome can occur much more quickly. There's 4 of these as well. There's a membranous interventricular septal defect. There's a paramembranous interventricular septal defect. These are membranous ones. They're typically small. Membranous defect. These can be really large, involve the entire membranous region of the interventricular septum. We just saw there's an example of a muscular defect, interventricular septal defect. Commonly occurs in more of the anterior region. Now this is rare, but you can be born without a muscular interventricular septum, and you have to have surgery really quick to beat that one, because you can't live with one ventricle very long. Here's an example of interventricular septal defects at different levels. We're not going to get into all these that specific, but there's a supracrystal one, paramembranous, and we're not going to go crazy into these things. Most of the time they're small. If they're under 5 millimeters in size, they usually will spontaneously heal with the passage of time, so no surgery is indicated. This is a moderate to large one in the interventricular septum right there. You can see that. What else do they have? There's an ASD right there. This one, atrial septal defect. The big problem again with these things is the risk for bacteria or virus or anything else growing, sticking to them, floating through the blood, latching on, and breeding and getting a huge population growth. And that can infect the endocardium, and that's an endocarditis. So that's the problem. As we've seen with the small ones can heal, but that doesn't mean these kids aren't at risk. And if your kid does have a VSD or ASD, and they grow up and it healed by itself, when they have dental procedures and things like that, they have to be careful. They should preemptively take antibiotics because they are at risk for a bug infection of the heart and endocarditis because of this kind of stuff. Bugs can stick to it. Normal people, it's too slippery. The slippery 3 aren't secreted very much in this area that was damaged. What about clinical features of a large ventricular septal defect? They have to be repaired. If anything greater than 20 millimeters, that's a really big hole, right? That's 2 centimeters. It's almost an inch. So that's got to be repaired immediately. Massive right to left or left to right shunt originally occurs. Eisenmenger syndrome will occur very quickly, probably within weeks, if not sooner. And yeah, they'll be in trouble. So they have to have surgery right away. All right, let's not go into the pericarditises. I think that's a good place to stop. See you. Let's see, do we have a test? No, we had our test already, so I'll see you on Thursday.